This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
All right, welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. I told you we'd be doing back-to-back episodes, and I was not misleading you. I promised you we would do it. Now, this is one of those fascinating stories I really wanted to talk about, because if you're like me, you're working in a children's hospital, you're an attending or you're a fellow or whatever you are, you're a nurse practitioner, whatever it is you do, you are seeing a lot of bronchiolitis, a lot more croup, a lot more of these viral issues that we don't typically see this time of year. And on a personal note, this is a pain in the butt for me because we do a lot of my episodes, a lot of my GME stuff for the fellowship during the summer because there's usually more time. So yours truly is not enjoying this. That being said, children are coming in and we are doing our best to take care of them. I am actually finishing up a service week right now. So I wanted to talk to somebody about this because I had read Australia had this happen in their summer. And for those of you who don't know, their summer is the opposite of our summer. And I know we have some listeners in Australia. So shout out if you're listening to me from Australia. Thank you for doing that. And their summer is from December 1st through February 28th. So like I said before, I couldn't think of a better person to talk to about this than friend of the podcast, Dr. Andrew Nowalk. Dr. Nowalk's an associate professor of pediatrics and clinical director in the Division of Infectious Diseases at the Department of Pediatrics at UPMC Children's Hospital of Pittsburgh and the University of Pittsburgh School of Medicine. He's a 1999 graduate of the MD PhD program at the School of Medicine. He completed pediatric residency and infectious disease fellowship training at Children's of Pittsburgh before joining the faculty of the School of Medicine in 2005. He maintains clinical practice and an active research program in Lyme disease. You all remember him from our Lyme disease episode, and serves as co-program director of the pediatric residency program. He has participated in data science research in diverse areas, including management and diagnosis of the febrile and hypothermic infant. And remember, we just had him on for our hypothermia talk. So, Andy, thank you for joining us again.
Tony, thanks for the invite.
So let's get our disclosures out of the way, as this is important to do. I will go first and kick it out to you. I have nothing to disclose relevant to this podcast.
I have nothing to disclose relevant to this podcast other than an obsession with CDC data reporting.
Well, that's helpful for here. I have to tell you, it's very helpful. So, Andy, I said this already, but, see all the news media are talking about, CNN, NBC, Fox, whatever you read, everyone has had it on there. This is a weird year. The medical literature is talking about it. We are seeing a lot of RSV, bronchiolitis, croup. Have we ever seen this before? What's going on?
So, Tony, I think what this touches on is another one of the many, many, many amazing ripples of the COVID pandemic that have reshaped a lot of what we do and what we think about. What we've done in the last 18 months in the U.S. and around the world is a giant non-IRB approved experiment in how you can moderate the incidence of individual respiratory viruses. And so what I want to take you guys back to is a typical RSV season. Let's call this the winter of 2019-2020. So when we were sitting in early February of 2020, in our hospital in early February, we had, I think I looked at these data last year, we had about 60 RSV positives in our hospital that week. We were going through our normal RSV season. It had started up a few positives in November. By the end of December, kind of solidly rolling. And normally that would roll until March or April and then peter out over time. Wintertime predominance follows along with influenza, although flu tended to most years start a little later than RSV for us. And then joined by lots of other viruses. Human metapneumovirus would be there at the same time, paraflu. So lots of things. That's a normal season. And we've always thought that's dependent on children as the primary mode of transmission. It's dependent upon people being in school together and daycares together in other places and spreading those infections. So then take everything I just said and then add in social distancing, add in schools that are closed, add in daycares that are closed, add in every human being possible walking around with a mask on, people limiting contact not just with their own friends, but their own families.
Yeah.
And that's what you get from March of 2020 through the majority of the year. So you take away a lot of what we thought were the risk factors. And if you look at the data, the RSV data just plummeted and it stayed down in a dramatic way as the United States was always in some phase of lockdown for about a year. So just to give you a reference point, I gave you the first week of February in 2020 at our hospital and said about 60 RSV positives in that first week of February. In, the United States reported to the CDC total in the same week this year. And I meant that the United States of America, there were 28 cases reported this February. So what we saw was an unprecedented reshaping of what we were doing. And many of us were wondering by the middle of last summer, what's going on? What are we going to see in the future? And so some other countries did non-IRB approved experiments too. And I like this paper from Clinical Infectious Disease about Australia because they opened up a bit. So they really opened up. They saw their normal RSV season disappear, but then they got to a much lower rate of cases. And unlike the United States, were able to get so low that they could open up a fair amount, bring kids back to schools, get kids back into daycare. And what they did very simply was move their RSV epidemic off by a complete 180 days. So rather than being in Australian winter, which is our summer, it moved into Australian summer, which is our winter. And so, the paper in CID is very convincing. You have a dramatic uptick in the detection of RSV when they brought all the kids together. And if you think about what's happened in the United States in the last 2 months, where most places have completely relaxed mask restrictions, people have gotten much more comfortable despite the Delta variant being out there. We've created the same conditions, and now we're seeing the same phenomenon.
Yeah, but Andy, why? Does RSV just kind of hang around and wait for kids and then pounce? You always read for flu, you had to be in an enclosed setting, windows closed, like in the wintertime, right? And here, everybody's outside. It's summertime. Is it purely daycares driving this? How's this happening?
I think daycares, families getting together. Just think of the number of times you've seen people saying, I finally saw my parents, my grandparents, my sister,
Mm-hmm.
my brother. We finally took vacation again. The airlines are bumping, the coastlines are bumping it on the beaches. So a lot of people are getting together. And, the great unanswered question, Tony, is it's a little bit of why in the first place are these respiratory viruses so exquisitely dependent upon winter? Is it all about people being crowded together? Go to Kennywood Park. There are lots of people crowded together there. Is it all about school? Does temperature have something to do with it? This reversal strongly suggests it's not a temperature thing. It's a people thing, but we still don't completely understand. I don't think we have a great handle, for example, on something you just brought up very smartly. Where's that reservoir? Where's RSV hanging out in the meantime? We know that the influenza pandemics start in Asia and tend to move across the world because the strains that we see there the previous year tend to predict the strains we see in the U.S. in the following year. But we don't know that for RSV and some of the other ones. So very confusing.
And even like paraflu, we're seeing so much croup. It really feels like winter when I walk through the wards when I'm on service. It's remarkable. And the paper, just for those of you who are listening, that's Clinical Infectious Disease Correspondence. It's titled "The Interseasonal Resurgence of Respiratory Syncytial Virus in Australian Children Following the Reduction of Coronavirus Disease 2019 Related Public Health Measures." It's to the editor. The authors are David Foley, Daniel Yo, Cara Minnie Smith. If I mispronounce everyone's name, I'm sorry. Andrew Martin, Ariel Mace, Chisa I'm going to mispronounce this name, Sikazwa, Hong Lee, Avram Levy, Hannah Moore, and Christopher Blythe. And this is from Australia, their infectious disease department at the in Melbourne, Parkville, Victoria. So has this ever happened before in history? Have we ever done this before?
We've never done this way where we were able to monitor in the way that we did. The last time we did something this dramatic, really, when you think about it, was 1918, 1919, 1920.
Yeah.
If you look at the pictures, it's a great time because we've kind of rediscovered that history. If you look at the pictures, everybody's masked as they're walking around because of the Spanish flu. So we've done this before. We just didn't have the degree of monitoring that we have now. And it's interesting, we got rid of everything. Right now, mostly what we're seeing is parainfluenza 3 with a vengeance. This is actually its natural season. So we tend to see summertime paraflu 3. So some of these viruses are popping up when they normally would. But I think a lot of it is just dependent on the fact that the masks are off now. And so everything's kind of crowding together.
Now, in the U.S., are we seeing any regional differences? Meaning, is the South, West, East, or North having more of a hard time with RSV and these wintertime viruses than other parts of the country?
Absolutely. There are very, very, very big differences. And one of the things that I would point everybody to is the CDC's fantastic data that's gathered together on, it's called the NREVSS, the National Respiratory and Enteric Virus Surveillance System, where the CDC in absolutely lovely fashion highlights different viruses and highlights what's going on in terms of detections of them. If you just flip to that website and pick out RSV, for example, what you'll see is RSV cases and percent positivity started going up in the Southeast, specifically in Florida, much earlier than anywhere else, which is typically how we see RSV. So we started seeing more antigen detections and we started seeing more PCR detections. That started as early as late March. So we started to see some signal there. If you flip to the same data for the West, they still have seen very, very little RSV. So, the Southeast is reporting a percent positivity for antigen detection at about 40%, and the West is stuck at about, I think, 2 to 3%. So dramatic differences.
Oh, wow.
The Midwest is closer to the South, and the Northeast is getting towards the South, but it's very clearly regional in the way things spread. Not a surprise, though, because that's what RSV does in a normal year. We see Florida outbreaks well before we see Northeast outbreaks, and the end of let's say a Synagis season, a palivizumab season in an individual place is often different, by a month or two, depending on where you live in the country.
So the difference in the West Coast versus the Southeast, you're saying, is normal. So are you then saying you expect this to continue marching west?
Yeah, I do. I mean, there's no reason for it to not do some of the things it's already done in past, knowing the behaviors we're showing now. So I would expect we're going to see the South, calm down before the rest of the country. And the West will probably, if I was going to guess, I would say that the West will probably be seeing significant cases in August and September.
So then this brings up one of my questions. In Australia, did this last the entire summer? Like, for us, are we going to be busy right up until our normal RSV season? And then do you predict we'll have one, or is this replacing it, or what?
Well, the Australian outbreak lasted a long time. And so it's come down, but they had a pretty significant season. If you look at the paper that you referenced and you look at, they looked at numbers of detections in West Australia, the peak, the normal average epidemic curve that they had like a 40 number for detections as the average in the way that they were measuring. And their peak for this RSV epidemic went up fast and hit a height about 3 times that. So they had a bigger epidemic. But the thing is, nobody knows. And I've seen models that show we're going to have a very mild flu and RSV season in the fall and winter. I've seen models that are predicting a huge one. And I can't say that I know which one's going to happen. I think if RSV bleeds over that far into the wintertime, that we're probably going to see a little bit more moderate of an outbreak. But I think, if there's a pause and then it comes back, it may come back with a vengeance. We could have according to some modelers, one of the busiest respiratory virus seasons we've ever had. And importantly, we're probably still going to be dealing with the lingering bits and pieces of COVID at that point.
Oh, geez. So we could be, with a mild pause, busy the rest of the year, the rest of the calendar year.
Yeah. You complaining about taking care of all this bronchiolitis. That may be a theme for podcasts for several months here.
Oh, man. Okay. Well, now, it's just so remarkable. I mean, when you think about this, first time that we've recorded it this well, and here we are, and we, even with our best, most brilliant minds in the country, and I'm a big believer in science, clearly, we're kind of like, we don't really know what's going to happen.
Yeah. Well, we've been dealing with, we don't know what's going to happen for 18 months, certainly. And I think we've hit the limits of being able to predict these things, because a lot of the big societal interventions that I want to give a shout out to masks, just masks alone, reshaped and saved probably hundreds of thousands of lives in the United States in the last year and a half. But they also reshaped how these viruses get transmitted. So I just don't know. It's pretty clear, I think, when you look around the country, that there's a strong and realistic intention to get kids back to school in person for the most part when we get to the fall. And whether that's going to be masked or not, you see tons of different proposals. How is that going to affect things? I just don't know for sure. My sense is, looking at these data, it says we're going to have a very, very busy respiratory season. How big, how long, where the peaks are going to be, I don't know. I'm getting very wary of trying to predict anything after the last couple of years. But I think that all the data are pointing very clearly to the fact that we had best buckle up.
Now, this is anecdotal. I've read a little on it, but what I have been seeing is, for the past year, like we just talked about, there was really no viruses floating around. So kids that are 12 to 16 months old may have gone their entire life at this point and really not seen a virus. And now that they're seeing RSV, I see those kids coming in a little bit sicker. And I'm seeing a skew older in my personal practice than younger, like I'm used to seeing. Is that a trend? Is that something we're seeing?
Yeah, I mean, I have not seen good statistics on average severity, but I talk to, my colleagues like you in hospital medicine all the time, and that's what I'm hearing. The first time you get RSV, depending on the age, it can reshape your respiratory destiny for your life, right? I mean, it can leave you with a predisposition to asthma and wheezing for the rest of your life. So it's not a surprise that if you just move that average age later, you're going to pick out a few kids who are still going to have severe disease. And maybe there is just something about the first episode, no matter what the age is. We certainly know that the age is an inverse correlation with severity, right? We know that the smaller the age, the higher the severity of RSV. But that doesn't mean that if you don't infect all those kids, they're not going to have a big bout of disease when they first get it from 16 to 18. We're conditioned to think that that's not the case, probably because so many kids get RSV in that first year, it really modulates the number of kids we could possibly see 1 and above who need to be hospitalized for RSV.
Do you know if there's any research going on now to ask about the reservoir question we discussed, where it was this RSV, or how did it all of a sudden pop up? Is there anyone looking into this that you know of?
Not that I know of, and that in no way, shape, or form says that that's not happening. And I don't know if it's a phenomenon where, you have a little bit of a trickle over from the involved areas as their pandemics go on that keep seeding the other areas. But we've seen RSV pandemics for, thousands of years. So what that suggests is that there are always a few reservoirs in your community, probably younger children who are shedding a little extra long, and they maintain enough of a chain of transmission that by the time they get to more susceptible people getting together and the weather is the right way, if that has any influence, that's what facilitates it. But that is me guessing. It's a great and interesting question.
So just to recap, in Australia, they had a severe RSV and respiratory virus and other respiratory viruses outbreak in their summer. It lasted the whole summer and bled into their fall and spring. And we are now in the midst of this. It started in Florida, like normal for RSV season, and is working its way westward. There's a chance that this could last the entire calendar year, and we can go from one RSV season to another. Models are predicting it. but we don't quite know. So we have to wait and see what happens. And this is the first time in really well-recorded history that we've seen this happen. And am I summarizing that well?
I think you're summarizing that beautifully. And I think, there's so many questions this article raises, which are interesting ones. Could this hit adults harder? If it happens all at the same time, are we going to get overwhelmed like the adult hospitals were with COVID, just with 5 different respiratory viruses? The number one that will always be RSV. Because as much as we talk about flu cases, you and I both know that for every one significant flu case we bring into the hospital in the middle of winter, we almost always have 4 or 5 or 6 RSV cases.
Yeah, no, I agree with that. Can I bring you back at some point, maybe later on in the season, and talk about where we are and where we think we're going?
Oh, yeah, because this, as I said, an experiment in progress yet again. Lots of people are going to study. Lots of people are going to study it along the way, and we're going to learn a ton, I think, about how RSV gets transmitted in communities, and also how do you set up the laboratory conditions for a really big year. It's interesting that so many of the people modeling this are predicting that 2021-22 winter is going to be outrageously bad in terms of not just RSV but flu, and that there is something about having a period of no disease that does seem to kind of set things up for a lot of disease.
That is fascinating.
Yeah.
And institutions around the country, I'm assuming their ability to do PCR testing like respiratory virus panel, et cetera, will have to be increased, or you think they've already made the transition from all COVID to COVID and RVP?
The nice thing is there are tons of regular RVP products out there for this. I think that I think what we really need around the United States is for the future, which I think will always be mixed seasons, including COVID-19. We need just a reliable multiplex PCR test that's going to get all of them at the same time. And maybe even, a trivalent flu, RSV, and COVID rapid test as well to detect all of them at the same time. Because it's hard for me to think that we're not going to have to be asking that question child to child as we go on, with ironically, the one of them that we're probably going to worry about the least is going to be COVID in that scenario, because we know it's the least impactful in kids. Although when you think about it, if you look at the numbers from the last year in pediatrics, COVID ended up causing mortality that was right in the range of influenza. So we didn't.
Is that right?
Yeah. It ended up being several hundred deaths in pediatric cases of COVID, which is just about where we are each year with influenza, a couple hundred deaths most years. So as much as we over and over and over again have talked about how benign COVID is, we've definitely had deaths around the country in children from COVID. They just have been dwarfed by what happened in the adults.
Well, Andy, that's everything I had to ask. Is there anything that we didn't ask that you wanted to talk about?
I think this is, for all of everybody listening, this is another tribute to the fact that the simple things we've done have worked tremendously well. Masking, you may think to yourself in the hospital setting, when you, in days before COVID, you're throwing on that gown, you're putting on that mask. You may think to yourself, I think this is overkill. This last year and a half have proven that it's not. This last year and a half have proven that those measures are really good, especially that mask, at interrupting the chain of transmission. In fact, they suggest that if all we did was wash our hands like mad and wear a good mask in a lot of these rooms, we would probably be 95% protected in the way that we need to be. So those simple interventions, here's the really interesting question, Tony, and I'll throw this to you. What's the Tarchichi prediction of when you and I are going to walk through the hospital and wave to each other on a ward and neither of us has to wear a mask?
Oh, wow. In the hospital?
Yeah.
2022 to 2023.
I would guess, and I wonder if what we'll see, if I were a hospital administrator or a public health person, I would say, well, maybe mandatory masking throughout the hospital starts every October and goes till every March, because we know we can protect all the staff that way, probably decrease the number of sick days, and it's a great way to protect our patients. I mean, we've learned that masks do a great job in reshaping respiratory virus epidemiology.
Yeah, and if you can have less doctors and nurses, because every year at Children's Hospital, doctors and nurses get sick, get a bad flu or get a bad paraflu, and are out for a couple of days. Mm-hmm. If you can spare that, I can tell you, even in my division, we've had one or two people have had colds, but that's been it. It's usually more. It's it's people who have kids in daycare. They get sick. Of course, the parents are going to get sick. But it's interesting. It really is. It
is. I mean, and when you think about that, that's a question I think about a ton. And I just throw that out to the audience. We now know that these interventions with masks are amazing in terms of what they do, especially knowing that COVID has more airborne potential than many of these other viruses. So something to think about as you move forward. Wear that mask happily because you're protecting everybody. And get ready to wear it, I think, probably more regularly for the rest of your career than you did before because of the data that we've gathered in the last 18 months.
That would be interesting. First heard it here, folks. You first heard it here, PHM from Pittsburgh.
There you go.
Thank you so much for coming on. This was a great talk. I really appreciate it.
Tony. Thank you.
My pleasure. My pleasure.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page. Create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, TARCHICHI, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.